Awesome. Hi, everyone, and welcome to the Public Health Youth Association of Canada's two-day Health Policy Hackathon. My name is Jacqueline Rinchma, and I'm the co-director of PHYAC, and I am also joined by Maham Tariq, PHYAC's other co-director. So as you know, the theme of our conference this year is the social determinants of health and health equity. And we have 150 participants signed up today with 39 teams entered. And we're so excited by the number of people because we know all of you are driven and passionate about generating creative and innovative policy solutions to address the social determinants of health and reduce health inequities. So we can't wait to see the policy solutions that you come up with at the end of this conference. And we hope that this weekend will give you a chance not only to think critically about how to address a complex public health challenge, but also the chance to connect and learn from like-minded youth from across Canada, and to think about how you can start to enact change both within your communities, but also globally.
And with that, we are so honored to introduce our speaker, Dr. Peter Singer, who will be delivering the opening remarks for our conference, followed by a period of Q&A. So please feel free to write your questions in the chat box on the right side of your screen on YouTube throughout Dr. Singer's talk and afterwards. Dr. Peter Singer is a special advisor to the Director General of the World Health Organization. He is the former Chief Executive Officer of Grand Challenges Canada. He's also a professor of medicine at the University of Toronto, director at the Sandra Rotman Centre of University Health Network, and foreign secretary of the Canadian Academy of Health Sciences. Dr. Singer has dedicated the last decade to bringing innovation to tackling the health challenges of the world's poorest people. He is well known worldwide for his creative solutions to some of the most pressing global health challenges. Thank you so much, Dr. Singer, for taking the time to be with us today. So without further ado, I'll now pass it over to you.
Thank you so much. It's great to be with you, Jacqueline and Maham, and to everyone listening. I'll do some introductory comments and then very much looking forward to the question answer period and addressing questions and comments that you may have. And also feel free to tweet during these comments at Peter A. Singer and just tag me. I want to start by talking about where we're at in COVID, some lessons from COVID, the role of young people in relationship to this, go from there to a focus on vaccine equity, and then end with some advice to young people, because I'm so excited to be with you for this policy hackathon where you're trying to identify solutions to big problems. So where are we at with COVID? You know, I think it's obvious that COVID is the worst public health crisis in 100 years, and one of the worst global crises probably in 70 or 75 years. Sadly, 2.9 million people have lost their lives. And cases are rising around the world and in Canada. Variants are surging, and we're seeing heartbreaking stories of often essential workers in intensive care units in Canada and, of course, elsewhere, who are losing their lives, and very, very heartbreaking stories. On the positive side of the ledger, we're seeing the rollout of the vaccine, or vaccines plural, for COVID around the world. And if there's one overarching message I'd like to give, it is that this will end, and there is hope, and the recovery will come. Now, with that, you know, I want to say, and I'll come into this in a moment, that one of the key lessons of COVID, even though there's been incredible and unprecedented progress in science, you know, the vaccines within a year, completely unprecedented, and huge amounts of increasing literacy on public health and increasing behavioral insights on public health, masking and avoiding poorly ventilated indoor spaces, the physical distancing, and so on. One of the, I think, really most significant lessons of the pandemic has been the lesson of equity. In fact, if there's three lessons from the pandemic, it's equity, equity, and equity. And this means that the pandemic has shone a very harsh light on the pre-existing social and economic inequities. You see that, for example, in a place like Toronto, where 50% of people come from racialized communities, but initially the hospitalized COVID cases came 80% from racialized communities. So it just shows the disproportion of the pre-existing social inequities. You also see it in the cases of essential workers, who sadly are in the intensive care unit even today. As people who can't stay home and do Zoom, they have to go to work, and often in crowded housing, often through public transport where they may not be able to physically distance and so on. So the lesson of the pandemic generally has been equity, notwithstanding incredible advances in science and the increase in literacy and the focus in public health. And in closing off the introductory part of these comments, just before I go to the focus on vaccine equity, I want to come back to you. I know there's a lot of young people listening, which is why I'm so thrilled to do this. What I want to say is that equity is in your hands. Equity is in your hands. And it's so terrific that you're here at a policy hackathon, a health policy hackathon, where actually what you're doing is my top line advice to young people, which is find a problem and solve it. And earlier today, I really had the privilege of looking through some of the policy briefs that were posted on the website on long-term care, on the rollout in Indigenous communities, on social and economic determinants, on digital health, and on many, many other issues. And it was really terrific to see that, and looking forward to hearing how the next couple of days goes. So that, I think, lays the groundwork for the comments that you will make, the questions and answers that you will have. But let me zero in on the second part of these comments, having painted a broader picture of this crisis, where we really are in the darkness before the dawn, but the dawn will come. And it's really shown us a thing or two about equity. Let me now focus more specifically on one type of equity, which is vaccine equity. Vaccine equity is the defining challenge of 2021. Vaccines are not a magic bullet. They need to be accompanied by public health measures, but they're making a huge difference. There's about 700 million doses of vaccine that has rolled out, or vaccines, plural, because there's several different types on several different types of platforms. We get into that, of vaccines that have rolled out around the world. But the most shocking part of that is how unequal that rollout has been. So there are 5 times as many, the rate of vaccination, for example, is 5-fold in high-income countries, like Canada, the United States, the United Kingdom, et cetera, versus non-high income countries, which includes upper middle income countries, lower middle income countries, and low income countries, where most of the people in the world live. A 5-fold difference between high income countries and non-high income countries. So the vaccine rollout in Canada, for example, is approaching 1 in 5 people having received a dose of vaccine, at least 1 dose of vaccine, with vaccination rates rising. And that is better than most other countries in the world. And so the vaccine equity issues, I think, are really, really important in that 5-fold difference. When you compare high income countries, not to non-high income countries with all those categories, but just to low income countries, the poorest countries, there's more than 100-fold difference. So that shows you how stark vaccine inequity is. Why is vaccine inequity bad? Well, it's bad for moral reasons. It's obviously immoral, unethical. My friend and colleague, Dr. Tedros, has said the world is on the brink of a catastrophic moral crisis, brink of a moral catastrophe. It's also bad economically. It's impossible to restart the world economy until everyone is vaccinated, and that's causing about $9 trillion of damage, according to some estimates of economic damage. And it's also bad in terms of peace and security, because I think the national security of countries depends on putting COVID behind us everywhere. So vaccine inequity, the defining challenge of 2021, is bad for all kinds of reasons, not to mention the public health ones, that in places where the virus is surging, that's where variants are arising. And it's very obvious that the variants even now are traveling around the world. We see, for example, the P1 variant, which was originally resurgent in Brazil, being found, for example, in British Columbia, and other variants across Canada. But anyway, so vaccine equity is the defining challenge. It's bad for a number of reasons: scientific, moral, economic, peace and security. And then the question is, okay, well, why do we have it? Why do we have vaccine inequity? At the moment, the choke point is on the vaccine supply side. There are definitely problems or challenges that will be there, that are there in the rollout and distribution, things like vaccine hesitancy, and just the act of distribution itself can be quite challenging. But the real chokehold, the real choke point is on the supply side at the moment. So then if you ask yourself, why is the supply deficient? There's really three possibilities in terms of what could be scarce. It could be dollars, it could be doses of vaccine, or it could be domestic manufacturing capacity. So think about that as the 3Ds. In terms of dollars, there definitely is a scarcity of dollars. For example, the Access to COVID Tools Accelerator that's led by WHO, which is developing vaccines and diagnostics and drugs, including oxygen, and helping to distribute those around the world equitably, is short 22 billion for this year. That might seem like a lot of money, but it's not a lot compared to the tens of trillions in stimulus spending that we see around the world. So there is a shortage of dollars. In terms of doses, there is definitely a shortage of doses. Even if you had the dollars, you might not be able to have the doses of vaccines. And WHO has called for countries that do have high levels of vaccine procurement to share some of those vaccines so they can be distributed or redistributed equitably around the world. And the COVAX facility, which is led by WHO and Gavi, the Vaccine Alliance, and CEPI, the Coalition for Epidemic Preparedness Innovation, and UNICEF, is the world's best redistribution mechanism at the moment. In the last 4 to 6 weeks, COVAX has distributed 38 million doses of vaccine to more than 100 countries, and 20-some of those countries would have no other way of getting that vaccine. And by the way, about 194 countries and economies have started vaccination out of about 220. And if you think about the ones that actually have the vaccine and haven't quite started yet, or just about to get the vaccines, that's 206 out of 220. And a lot of that is due to COVAX that's starting, but the emphasis is on start because many of these still have very low vaccination rates, often starting with vaccination of health workers. So it could be scarce in dollars, and we are. Could be scarce in doses of vaccine, and we are. And WHO is encouraging the sharing of vaccine. But the real problem is, especially in the midterm, on domestic manufacturing. And we have a history of this in Canada. If you just think about things like the Avro Aero or the sale of Connaught Labs, these are examples where our domestic manufacturing and innovation capacities in Canada, in a sense, have been historically hollowed out. And we have the same problem now with domestic vaccine manufacturing, but it's a problem that exists in Canada and around the world. So WHO is engaged in 4 approaches to try and address this. One is fill and finish, trying to help with matches on fill and finish. That's the final stage of vaccine production where you put it in the bottle and you can ship it out. Secondly, bilateral technology transfer. So example of that would be Oxford AstraZeneca to Serum Institute in India. Thirdly, and this is, I think, probably the most important, or certainly very, very important, is a coordinated form of multilateral technology transfer. This is what WHO did between 2006 and 2016 in terms of influenza vaccine, to really ramp up the capacity of influenza vaccine around the world. It's the same thing that could be done with COVID. Technology transfer essentially is translating the know-how of how to make these vaccines to different places around the world. And you can imagine a situation where every region in the world at least has at least one manufacturing facility or hub to be manufacturing vaccines. That's a very important way over the next 6 to 12 months, shall we say, to increase supply, to deal with the vaccine equity issues through that translation of know-how. And then the fourth way is intellectual property. And WHO has supported the proposal of India and South Africa at the World Trade Organization to put a temporary suspension, if you will, on intellectual property rights related to COVID-19 technologies. So in summary, vaccine equity is the defining challenge of this year. I noticed that that wasn't yet the focus of some of the policy briefs, so it may be an area where you want to focus. It's bad for a number of reasons: ethics, economics, peace and security, and the plain fact that you can't end the epidemic anywhere with variants surging until you end it everywhere through solidarity. And then the idea of asking, okay, well, what's scarce? At the moment, it's more on the supply side than the distribution side. And on the supply side, the scarce things could be dollars, doses, or domestic manufacturing. And so one place that you might focus in one of your policy briefs, and I do think that this is public health, by the way, because these are areas where science and public health all come together, and innovation and manufacturing. One area that you could focus in, at least one of the policy briefs, might be on domestic manufacturing of vaccines in Canada. And there's been some development on that as well. Anyway, vaccine equity, or really I should say vaccine inequity, as a defining challenge. Now, finally, in closing, having talked about the general situation and the importance of equity and the lesson that we've learned around equity in COVID, the focus on vaccine equity. The third thing I'd just like to talk about briefly is some advice to young people, because that's what you are, and you're in the process of really beginning your careers in many cases, and you will make a difference. You'll make a difference in COVID. COVID offers opportunities to make a difference. You can see that in your policy briefs, and you can see that many of them actually already focused in on really what is one of the defining challenges of COVID, which is equity. So my top line advice to young people, you've already taken, which is find a problem and solve it. That's what you're actually doing here. What I'd encourage you to do is to follow through and really make sure that the problem's solved. Ask yourself how many people have benefited, see what you've learned from solving that problem, and be able to say a year from now, here's the problem I had, here's the solution I proposed. Yes, we worked on it as a team. Here's what we did. Here's the outcome. And here's what I learned. That kind of narrative is really important to you, I think, and find a problem and solve it. Secondly, embrace failure. Not all these things are going to work. All these policy solutions or other solutions that you're proposing. It's a mistake I made. I was always trying to put things very positively when I was young. It's a little defensive. Don't be defensive. Embrace failure. Sometimes things won't work. The issue isn't whether you're going to fail or not. The issue is whether you can fail fast and cheap and learn from it. And you can celebrate failure and you can celebrate learning, because that's how you'll go on to even greater success, from understanding the causes of failure. Thirdly, find the right mentors. When I was younger, I didn't really focus in on this enough. And a good way to do it is to ask yourself, okay, what do you want to be doing in 10 years from now? And who is doing, what 3 people are doing that most like what you want to be doing 10 years from now? And then reach out to them. And you'll be surprised that a very high percentage of people will be very happy to talk to you. And so there is a way to find mentors. I'd encourage you to find diverse mentors, but to find mentors. And speaking of diversity, the fourth bit of advice I would have is to acknowledge privilege and to lean out a little bit. So good ideas come from everywhere. It's just not everyone has the same opportunity. And whether that be gender, whether that be so-called BIPOC communities, lean out, make way, enable colleagues. I did it myself in Grand Challenges Canada. I was working with a couple of terrific women, essentially vice presidents. And I just started to recognize, wow, they can do this better than I can. And over time, I leaned out. I did less and less and less. They did more and more and more. And then there was an international search, and then they were appointed the co-CEOs. And they're taking Grand Challenges Canada forward in a very exciting way in a feminist co-CEO model. So acknowledge privilege and lean out. And the same thing would be the case in relationship to enabling leadership and representation of people from Black, Indigenous, and people of color and other communities. So next is hop aboard a rocket ship. If you happen to see a rocket ship moving beside you, jump on board. For me, the rocket ship was Grand Challenges Canada, and I jumped on board as a co-founder. You'll see a few of these in your career. Jump on board when you see it. And then finally, to use a Canadian hockey metaphor, go to where the puck is going, not where it's been, to quote Wayne Gretzky. In other words, go to where others are not. Everyone in public health goes to public health school, and that's terrific. But maybe going to a business school is going to be a good way to get to public health, or maybe going to an engineering school. Don't rule out different paths that are less populated. And for me, the example of this was bioethics. When I went into bioethics in the 1980s, there were very few people doing that, especially from within the health professions, trying to essentially reform the health professions from inside the health professions. And so I went there into an area that was sparsely populated, not highly populated. And that was an example where I was able to go where others were not. So advice to young people: find a problem and solve it, embrace failure, find the right mentors, acknowledge privilege and lean out, hop aboard rocket ship when you see one, and you will see one, and go to where others are not. So coming back to our main theme, it's just such a great privilege for me to be here with young people. It's so terrific what you're doing. I'm very excited about what you're doing, the solution orientation you're taking. The defining challenge of COVID, which is a terrible tragedy. But if there's any opportunity in that tragedy, it's that it's exposed the inequities. And now it's up to us to redress those inequities. And that gets into the problem solving and equity being in your hands. And that's why I've gone a little bit more expansively onto advice to young people. So you can really take off and achieve the impact that I know many or all of you are so impassioned to achieve. So with that, I want to just say it's really humbling and wonderful to be with you, and really look forward to engaging you now with your questions and comments. We'll also see you on Twitter at Peter A. Singer. And thank you very much, and really look forward to your questions and comments. Jacqueline and Maham, back to you guys.
Thank you so much, Dr. Singer. I think I can speak for all of us when I say that I'm feeling very inspired and driven to enact change and make an impact both within my community and globally. And you've given us some really incredible and tangible insights on how youth can be mobilized to become global change makers. So thank you so much. So yeah, we'll jump into the questions now. For our attendees, please feel free to write them in the YouTube chat. But just starting with this first one that we've been sent. So you highlighted a number of key health and social inequities that have been exposed and further perpetuated as a result of COVID-19, particularly the issue of vaccine equity. So as many of our members are working or will go on to work in public health, how do you think we can build an equity lens into future pandemic planning to prevent some of these disparities that we've seen?
That's a really great question. I guess the first thing is representation. Representation really matters. So a diversity of people in the room making decisions is probably the single most important single most important step. Having said that, explicit measurement of equity, I think, is really very, very important. There's some really interesting work happening using disaggregated data and disaggregated data measurement. We've seen it in Toronto, we've seen it in Montreal, in terms of which postal codes, for example, have what particular rates of COVID and what particular rates of vaccination. And in Toronto, for example, you see that the communities, the postal codes with the highest rates, and postal code obviously here is a shorthand for a whole host of social determinants. The postal codes with actually the highest rates of COVID are often the ones with the lowest rates of vaccination. So that just shows a very high degree of inequity. So one problem to solve is actually how to close that gap. And then how long it will take once you close that gap. How do you target the vaccination? How long will it take actually to redress those? And so a lot of very important, very interesting situations there. So second point after representation is probably to measure disaggregated data. And of course, that requires a sensitivity and an understanding that you care about equity and that you're focused on it and you want to deal with it. I think everyone, and maybe that's the third thing, maybe it should have been the second thing. I think everyone knew about equity before. The SDGs talked about leaving no one behind, but it was like this abstract concept that most people didn't feel and most people didn't live. You just have to now walk on the street or watch social media and you see the stories of essential workers who are in the ICU, who are dying. Incredibly heartbreaking stories. And those are stories of inequity. Those are stories of social determinants. Those are people who don't have the luxury of staying home, often from racialized communities, often from low-income communities who have to do frontline work, don't have the luxury of staying home. And so I guess that's the third thing. So maybe just those 3 points. I'll just stop there, Jacqueline, in case there's other points. Number one being representation really matters in the decision making. Number two being just the sensibility, the habit of mind to bring an equity lens to the situation would be very important in the recovery as well, not only in future pandemic preparedness, to redress the inequities that have been so shockingly identified. And number three, to focus in on disaggregated data and use that data to translate really to watch improvements and to watch. That's the point of disaggregated data. You show the inequity, you think about how you might redress it, you watch the inequities resolve. And you've seen some of that in Toronto as well, with some great work by people like Kwame McKenzie, the head of the Wellesley Institute. So there's good examples of that. I'll just stop there though, Jacqueline, on this very good question about equity and what to do with it for the next pandemic, but it's also for this pandemic and it's also for the recovery from this pandemic.
Thank you for that answer. The next question we have is, do you think that COVID has made us see loopholes that exist in healthcare all over the world?
Yeah, well, the place to start actually is how it's turned on its head some of our preconceived notions. So some of the countries that did best are countries in the so-called global south, so-called developing countries. Some of those did much better than so-called developed or so-called rich countries. So in a sense, it's really turned our perception of healthcare on its head. And for example, if you look just in G20 countries, there's a 50-fold difference in cumulative mortality across G20 countries, a 50-fold difference in cumulative mortality. What is that? Is that chance? Is that bias? Is that biology? What is that? Some of it's luck. Some of it's the type of public health measures, but some of it comes down to leadership and some of that active, early, decisive leadership. If you look at the traditional measures of pandemic preparedness, let's say the Global Health Security Index or the International Health Regulations core capacities, what you'll find is they don't predict mortality. So the idea of these static capacities, how much laboratory capacity you have, may be necessary, but it's not sufficient. And it's the dynamic actions. It's not necessarily what you have, it's what you do with it that really matters. And of course, the highest version of that is leadership. And so I do think it's shown loopholes, but not in the way you would have expected. We would have expected it to be around the laboratory capacity, around the stuff we were measuring as so-called pandemic preparedness. And that stuff's important, but what I think it really shows is the importance of the muscle memory of having done this with SARS-1. What it really shows is how countries that have to deal with polio already have the ways of public health surveillance and isolation of cases, quarantine of contacts, et cetera. And that's another form of muscle memory. And what it shows is that it's the dynamic aspects of decision making, and at the end of the day, leadership. And I don't mean just at the head of state level. I mean at every level, including in communities, that really matters. So yeah, it's shown some really interesting things about health systems. And by the way, it's also not correlated with universal health coverage. So those kind of measures of no. It's the dynamic decision making around preparedness, and we don't have good measures of that. And so it's shown some very interesting patterns other than what you might have otherwise have expected.
Thank you so much. And we had a question from an audience member just on that note of SARS. So they're wondering, how much do you think the 2003 SARS outbreak has prepared us for COVID, and did our approach change, or has it been different in any way, or more or less the same?
So there has been some preparedness. Some countries, for example, in East Asia that had a terrible experience with SARS have done extremely well with COVID. In Canada, I noticed one of your policy briefs was on long-term care. We really had two epidemics in Canada. We had the epidemic in the community, and we had an epidemic in long-term care facilities. And it's more than 80% of the deaths were in long-term care facilities. And so that's a particular and very, very tragic issue. And it's great to see, I think a couple of the policy briefs were directed against that. But I think that this is obviously much worse than SARS. I remember SARS. I lived through SARS. We wrote about the ethical issues in SARS and pandemic ethics and so on. But this is much worse than the 2003 SARS. What we do know is every few years something bad happens, whether it's SARS, whether it's H1N1, whether it's MERS, and now COVID-19. The way that humans and nature, animals are closer and closer together provides a regular cycle of outbreaks. They don't always become pandemics like this. And that's the real trick, is how do you stop an outbreak from becoming a pandemic? And some of that, of course, depends on the biology of the virus. Some of it's just unstoppable. But I think that, yes, this learning from SARS, but what this also shows is the regularity of outbreaks, the regularity of threats of pandemic potential in the past and into the future. And historically, unfortunately, it's been a cycle of panic and neglect. And so you panic and then you neglect, and you don't fully finance the preparedness plans. That's exactly what happened in the last few years. So it's not as though people didn't see this coming. Dr. Tedros, a year before this started, was asked, what keeps you up at night? He says, a virus of pandemic potential. And so it's not as though people didn't see it coming. It's that we didn't take the actions needed to prepare. And let's hope that now we will.
On that note, there was a question asking about, many of us are seeing a mass increase in misinformation. and resistance against public health measures, or a lot of vaccine hesitancy growing because of the misinformation and debate between which vaccine type is better, AstraZeneca versus Moderna versus Pfizer and Johnson & Johnson. So what are some strategies we can take to address that growing mistrust?
So let me just say clearly that WHO's recommendation is take whatever vaccine is offered that is authorized in your jurisdiction, that's offered by your local public health authorities when it's offered to you in the allocation scheme of the jurisdiction. That's our advice. The issue of misinformation more generally is really serious. And misinformation isn't always a lack of information. Misinformation has all kinds of root causes, including ideology, culture wars. I mean, there's a lot going on with misinformation. In terms of combating misinformation, it's really about trust. So, you know, I noticed, for example, you mentioned vaccine hesitancy. One of your policy briefs is on Indigenous communities. I'm hoping that when the story of the pandemic is told, and the Canadian response in particular, that the chapter on Indigenous communities will be a happy chapter. We actually see a lot of efforts by Indigenous communities themselves to vaccinate, to have community leaders start that. That's the trust element. You know, there really does, at least to the external observer, seem to be an honest application of nothing about us without us, a really Indigenous-led effort. We'll see if that turns out to be true, if that turns out to be as effective as I hope that it will be. But I'm hoping that that could be a happy chapter, especially given the shameful history of the relationship between Canada and Indigenous communities historically. So I think in misinformation, there's a lot going on. A lot of it has to do with trust. A lot of that has to do with community leadership. I gave a specific example in terms of Indigenous. I sidetracked a little bit into vaccines to just make a clear point about take whichever one is offered. And then, you know, obviously a lot of this comes out in social media. And social media has made the misinformation thing a lot worse, which is why WHO has worked very closely with social media companies like the big tech companies, Facebook, and Google, and Twitter, et cetera, and comparable companies around the world. If you go to Google now and you enter something related to COVID, you'll end up on a page that probably has a lot of WHO information on it, alongside others, even in terms of gaming companies. You know, you'll see WHO information going down gaming channels, which goes to tens of billions of people. Public health information about masking, physical distancing, ventilation, et cetera. So I think misinformation is a real problem. I think it's a core issue is trust. It relates to some of those equity issues that we talked about. It is exacerbated by social media, but on the positive side, there have been some real opportunities to work with communities, to work with faith leaders, for example, as WHO has, and to work with some of the large social media companies to try and tackle what's been called an infodemic, which is really the kind of shorthand for these problems of misinformation. At the heart of misinformation is not lack of information, it's trust.
Thank you. So you mentioned the importance of sharing vaccine supplies, but are there any other ways that Canada can take a leadership role to help support and accelerate vaccine equity on a global scale during the pandemic? And then sort of second to that, what are some potential ways that youth can address and advocate for redistribution of vaccine supply to lower income countries?
Yeah, thanks, Jacqueline. So the first thing to say is Canada already has taken a leadership role. It's been a lead player, for example, in COVAX. So it's one of the top financial contributors to the COVAX facility, which is probably the best bet that the world has to equitably redistribute or distribute vaccines. And not only in terms of dollars, but also in terms of engagement in COVAX by senior officials, ministers, and others. and here, particular shout out to Minister Gould, who's the Minister of International Affairs, who actually leads the engagement council, co-leads the engagement council with COVAX. So dollars and engagement, Canada's there. Doses, the dose issue is a real challenge, and it's a domestic political challenge. But what countries don't want to do is to have vaccine nationalism. And so there have been proposals. For example, President Macron has proposed that I think 5% of vaccine doses in real time should be redistributed. Dr. Tedros has asked for 10 million doses to be redistributed from countries. And so I think when, and hopefully that when will be soon, like tomorrow or today or maybe yesterday, when it is possible to do so, that some such sharing does occur from countries that do have ongoing, increasingly effective rollout. And just to say that COVAX is up and running and provides an easy mechanism to do such redistribution. And here is where the young people really come in, because governments generally want to do the right thing, but they have domestic political constituencies, domestic constituencies that they need to listen to. If they have a lot of young people asking them to please share vaccines, it's much easier for them to share vaccines sooner. And that's the fact of the matter. And this is something that takes quite a bit of soul searching. So, for example, as personal for me, I had an opportunity to get vaccinated. I signed up in the Swiss thing. I got this text, this would have been weeks ago, that said, okay, here, your appointment is at this place at this time. And I thought about it. That was at a time when not a single health worker in Africa had yet been vaccinated. And I thought to myself, this doesn't feel right. So I put it off for a week. They won't only let me put it off for a few days, and then I put it off again, and then they wouldn't let me put it off a third time. And then I said, okay, fine, cancel it. And then they called me 6 times. And it was like almost impossible not to get vaccinated at that point, but I just stopped answering the phone calls and then didn't get vaccinated at that point. Now, my risk might be a little lower because I actually also had COVID about a year ago, a mild case. But that shows you that these personal decisions by young people, by yourself, these are tough decisions. And at least advocating can really be important. I've now re-enrolled, but haven't yet been vaccinated because I haven't yet been called. So that's the kind of doses. And then on domestic manufacturing, if you're a young person who knows about vaccinology, manufacturing, engineering, mRNA, adenovirus vectors. There's a lot of scientists listening among the young people. I think a quarter of the people are graduate students, many are undergrads, probably some in molecular biology and sciences. Don't go dig a well. Use what you know to help. And this is a place where young people can really help. The vision here would be to have domestic manufacturing in every region of the world. There are connections where you can help with your expertise, with your knowledge, et cetera. So I've gone on a little bit too long about that, but in terms of dollars, not bad. We're still a shortage, need more. Canada's really stepped up, including with engagement. In terms of doses, it's a tough one. But if young people raise their voice, and I'm not just talking about Canada here, the United States, any country in the world, it'll be more likely that governments will listen. They want to do the right thing. And then in terms of domestic manufacturing, many young people have scientific expertise and really thinking through how you can contribute, how you can help, maybe starting with a policy brief on this topic, maybe even for Canada. And there's a lot of issues of technology transfer of intellectual property and other things involved here that are quite nuanced and important. So there's some ways that people can get engaged to deal with some of the bottlenecks on supply. And the variants make this even more important, especially the domestic manufacturing, because it might be more like antiviral software in the real world. How there's viruses popping up always in the virtual world, and you've got software on your computer, and it detects them and it deals with them. Well, we could have a world in the future that looks a bit like that.
Thank you.
And that, by the way, ups the need for manufacturing, obviously, and ongoing booster doses. We don't know whether you need that yet. WHO is not recommending that yet, but if you're future oriented, it's a possible world that's coming.
Yeah, thank you for that. On that note, what skills do you think are most important for youth and students to have working in the field of global health?
Leadership. And what does leadership mean? It means it means in this case that you're able to take a principled approach. I mean, if you look at, for example, my friend Dr. Tedros, the Director General of WHO, look at the pressure somebody like that is under. Look at the pressure over the past year and a half. He's the epitome of Hemingway's phrase, guts is grace under pressure. Think about scientific leadership, scientific principles, following the science, following the evidence. Look at the cases where that hasn't happened around the world and what's happened in result of cases and unfortunately deaths. Empathy. People are looking for leaders who understand them in terms of feeling. It's not all about thinking. A lot of this is about feeling. Equity and standing with disadvantaged communities. That's a conscious decision. It's a habit of mind. We talked about that before. A really important part of leadership. Being honest, communicating well, and acknowledging mistakes. Is something that builds trust on the part of leaders. So I think and also having a realistic dose of optimism and being able to offer hope. All those things I think are characteristics of leadership. Leadership happens at the highest political levels, and it happens in every community and in every family and in every classroom that you're all in. And so, if there's one skill that I think rises above everything else, it's the skill of leadership and being able to listen and take a diversity of views and build a team. These are all other characteristics of leadership, and leadership can be learned and it can be improved. For example, just to be very personal about it, in 2006, when I finished leading the Bioethics Center, I went to Harvard Business School for a 2-month course on executive management, kind of a mini MBA. And part of that was you got 360-degree evaluations from the people that you worked with before. So I started reading these evaluations, and basically it said, oh, great strategy and vision, but doesn't really build interpersonal trust. And then my first reaction was really defensive. Yeah, I talked about this before, in terms of my own failings. But then I thought, you know what? It's right. And so once you embrace that kind of contrary view that can be very uncomfortable, you can actually improve as a leader. And then later on, I'm an executive coach. This was in Grand Challenges, Canada. And I was working, as I mentioned earlier, with a couple of really terrific young women who are terrific leaders. And there was some tension and some frustration on their part, and we discussed it. And it was kind of like, they felt I was micromanaging. I thought to myself, and actually the coach said to me, "Well, look, do you trust these people or not?" I said, "Of course I do. They're fantastic." And then she said, "Well, why are you doing this then?" I said, if you trust them, just empower them and let them follow their vision, and it'll be okay, and it'll probably be better than what you did. And that's actually what happened 3 days ago, by the way. They and this is also a big thanks and shout out to Canada. Those two, Carly Silver and Jocelyn Mackey, one's a Rhodes Scholar and a scientist, the other's an intellectual property lawyer. And they have this very interesting feminist co-CEO leadership model that you can read about on the Grand Challenges website. They led the organization into a successful refunding of $200 million from the federal government to keep doing that amazing work that Grand Challenges Canada does on innovation with impact in development, and by the way, also now in Indigenous Innovation Initiative domestically. Anyway, you asked about skills, I talked about leadership, and then listed some characteristics of leadership. I pointed out that everybody on this call should be reflecting on their own leadership. That's really what I was pointing out as I was talking about my own failings and thinking about how you can improve your leadership, because we all can. It's a skill that can be improved. And then I gave you an example, and maybe the place to end is, early on you talked about the global and the local. Global leadership can start with local leadership. Find the problem that's right in front of you and solve it. And my example of that is when I came back and started working as a doctor, I was focused on end-of-life care. That's what I wanted to improve in ethics. And I started sending these surveys, on living wills to nursing homes and their policies and stuff like that. And at the same time, there was a medical ward right outside my office where like 15% of the patients, unfortunately, were dying. General internal medicine, that's the mortality rate on inpatient general internal medicine. And so I didn't go to that ward and say, how, are those quality end-of-life deaths? How do we improve them? I had a problem right in front of me that I didn't solve. And I was kind of distracted elsewhere. And that's a good example. And then I started in global end-of-life care. And there was a local problem sitting there right in front of my face that I should have just paid more attention to much earlier. And I think that's the case here in the situation and the opportunities given by the COVID recovery.
Great. Thank you so much. Yeah, that's such great advice. I think especially with some of these global challenges like climate change and COVID, I feel like a lot of youth feel as though their actions, don't matter or that they won't be able to have an impact, but it's all about thinking locally in order to enact change globally. So I think that's great advice. Thank you. Sort of just on that note of innovation, so we had a question, could you briefly speak on the role of technologies when it comes to deployment of healthcare and services during COVID-19, maybe potentially any opportunities, but also challenges that you've seen arise?
Yeah, terrific. And by the way, on the point you just made, leadership is the ultimate vaccine against the interlinked challenges of climate, of pandemics, of racial injustice, of economic inequality. These are all interlinked challenges, and leadership is the final common denominator, the ultimate vaccine. Vaccine in quotes. In terms of innovation, here I'll talk about some thinking that the late Joe Rotman, some of you probably know about the Rotman School of Management at the U of T that he endowed, very successful merchant banker, entrepreneur, who then turned his attention to not-for-profits in the last 20 years of his life and was the founding chairman of Grand Challenges Canada. And early on, we had to define what we meant by innovation. And we came up with this idea of integrated innovation, which is the conjoint application of innovation, social innovation, technological innovation, business and financial innovation. These things all come together and integrate. And that's how you accelerate innovation to scale. So innovation does not equal, first of all, it doesn't equal invention. And because it's actually the translation of inventions and inventive ideas into the real world for impact. And secondly, innovation does not equal technology. So it may involve technologies. But what we found actually was a lot of the stuff we were funding was social innovation, service delivery innovations. So I just wanted to offer a broader concept of innovation. Now, specifically with respect to technology, which was the question, there's a lot of technologies that will come into play here. So on the preparedness front, for example, there's a little company in Toronto called Blue Dot. And Blue Dot uses AI, uses big data in a very interesting way. It actually identified the pandemic on the same day that WHO identified it. So it didn't identify it earlier, but it did identify it on the same day, December 31st, 2019. It was able to project right away the top 10 cities that it would spread to. So there's obviously data science, data innovation, and some of the stuff we were talking about before in terms of static versus dynamic capacities. and disaggregated data. All that has to do with data science. And that requires an IT technological base. The question was about technology. Vaccines are maybe the best example of technologies here. The remarkable progress. I'm not sure many people realize, but you think about this Pfizer BioNTech, you think about Moderna, these are the mRNA vaccines. This is the first time there's actually been a licensed or emergency use authorization anyway, mRNA vaccine. There are no other mRNA vaccines. And then if you look at other vaccines like the Oxford AstraZeneca or the J&J, these are viral vector vaccines. There's only one previous example of such vaccines, and that's the Ebola vaccine. And then if you look at some of the protein vaccines that haven't really come yet, Novavax, for example, there's several more examples. And then if you look at some of the inactivated virus vaccines, like the Sinovac, the Sinopharm, there's lots of examples of that. And so there's a really interesting interplay here between different types of vaccine technology platforms and how that technological story is played out. So the vaccine technology platforms are really interesting. And then even simple things like oxygen innovation. We were involved in helping an innovator, Michael Hawks from the University of Alberta, who developed solar-powered oxygen in terms of starting to scale that in Somalia. And it's already started to save lives in COVID. But, there's, I think, 800,000 deaths of children under 5 from pneumonia every year. 20 to 40% could potentially be prevented with oxygen. Many of those kids don't get oxygen. It's a very, very supplemental oxygen. I'm not talking about a ventilator. I'm talking about just, it's a very good way of thinking about how technology, in this case, a device, can very quickly save lives with the solar powered innovation aspect of it, for example, addressing the issue of limited electricity in certain settings. So the question was about technology. I gave some examples of technologies, be it oxygen, which is, by the way, a drug. Think about it as a drug, as an essential drug, be it vaccines, terrific example, be it data science. But then I embedded that earlier in a broader notion of innovation that embraced social innovation and technological innovation and business and financial innovation as well, and this idea of integrated innovation that originated with the late Joe Rotman, who was a terrific mentor to me.
Fantastic. Thank you so much. I just want to be mindful of your time. I know that we could probably go on all day asking you questions, but thank you so much for your incredible insights. We are so appreciative of your time and just wanted to give you the opportunity if you had any final things to say to our audience members. But again, thank you so much. We are so appreciative.
I really appreciate the opportunity, and maybe I just make a couple points. One is just to say how terrific it is what you're doing, because you're focused on solutions. But don't just leave the solutions on a piece of paper in a policy brief and leave it there. Follow it through and see what impact you can have. And then once you've done what you can on that problem, go on to the next problem. Because one way to think about a career is not the title. And this is some great advice I got from the late John Evans, who was, for example, the founder of McMaster Medical School, where I know, Jacqueline, I think you go, right? Anyway, to the public health school there. And, he said, it doesn't matter what it says on the outside of your tombstone, it matters what it says on the inside of your tombstone, by which he meant it doesn't matter what your title is, it matters what you've actually accomplished. And the way you accomplish things is by finding a problem and solving it, taking it as far as you can, implementing it, through to measuring, through to being able to say who you've helped and have the metrics of success, and then going on to the next problem. So what you're doing here is really awesome. And it's going to get supercharged in the time of COVID, where it's so obvious that there's such painful problems to solve, especially in the area of equity. I use the example of vaccine equity, but there's a lot of social determinants and other determinants of health, and more broadly, social protection, which is, you had a policy brief in there about paid sick leave. and the relationship to essential workers. And that's a very, very key example. And then finally, just on the issue of leadership, you know, that's what I mean when I say equity is in your hands. And that's an act of leadership, and it's an act of leadership on your part. Each of you is a leader, and each of you can further develop your leadership skills. And the reason I went into the negative experiences I had and where I made mistakes is I don't want you to make the same mistakes. There's absolutely no reason for you to waste your time making some of those same mistakes. So find your passion, follow your passion, and find a problem and solve it. Use some of those other bits of advice. I posted that list, by the way, on social media, on Twitter, on Facebook, on LinkedIn, and would be glad to stay in touch after this, but at Peter A. Singer. But the main point I want to make is just keep doing it. You know, the only way to do something is to do something. And that's what you're doing. And it's just terrific. And it's great to be with you, and really enjoy the next couple of days and make the most out of it. And most importantly, save and improve the most lives that you can as a result of the solutions that you are about to undertake. So thank you very much. It's a great privilege to be with you, and I think we're good.
Fantastic. Thank you so much. Yeah, and I think my favorite point was about hopping on a rocket ship. I think that's fantastic advice. So thanks again. And we encourage all of our audience members to follow you on Twitter and also on LinkedIn as well. So we really appreciate your time. Thank you again.
Thank you so much.
Thank you. Thanks to both of you for your leadership, and thanks to everyone listening. Bye-bye.
Bye. Take care. Awesome.
So just to summarize the rules for all of our participants, again, you guys will be working in teams of 2 to 5 to submit a 2-page policy solution to Canada's most pressing health issue. Our theme this year is the social determinants of health and health equity. Participants are highly encouraged to attend the 4 workshops throughout the day, as they will help them write their briefs and gain inspiration. Policy briefs are due tomorrow by 10 a.m. Eastern Time. The Dropbox link and submission guidelines can be found in your delegate packages. Winners will be notified by 3:30 p.m. Eastern Time tomorrow and present their briefs at 5:00 p.m. Eastern Time. The winners will also get a chance to talk to MP leader Jagmeet Singh and Candace Sayah-Aubin, the Vice President from the Health Promotion and Chronic Disease Prevention Branch at the Public Health Agency of Canada on Wednesday, April 14. All participants can join this meeting using the link in the delegate package. One participant will be given the chance to join this conversation by posting on Instagram, Twitter, and LinkedIn using the hashtag PHYAC Hack for Health Equity as written in your delegate package. If you have any questions, feel free to contact us on any of our social media platforms or email us at contact@phyac.com. You can also find all our emails and links to our social media in the delegate package. And good luck to you all, and we look forward to reading your briefs.
Awesome. And just as a reminder, we have our first workshop starting at 11:15 with Kim Parada, who is going to be speaking on improving health and health equity while fighting climate change. So a really important and crucial topic that may help to inform your policy brief. So we highly encourage you to attend, and the Zoom link is in your delegate package. Thanks so much, everyone. And we look forward to connecting with you further throughout the weekend. If you have any questions, like Mahan mentioned, please send us an email at contact@phyac.com.